Well, good morning, dear students. And today I start my second lecture. The first one was dedicated to the history taken, to the part of the history, which are the framework for any healthcare professionals. So after taking the history, we additionally also assess the functional history of the patient, which I will put into the last part of my lecture if we have time, or if not, I will continue it on the next lecture. So after getting the history or collecting the anamnesis of the patient, it's very important to go through the general survey, which has general survey means that we are checking fully or we are asking additional questions now about the health condition of the patient, and of course we have to get the vital signs of the patient, and as well if patient has pain we have to assess to make the assessment of the pain also. So in general survey there are a few questions which are usually concerned and they could be common of the common complaints, but specifically we have to ask about them also. First of all, that is the fatigue and weakness. Uh, very often, very often, patients themselves might interplace or these two words with each other, but we have to understand that they are totally different from each other. First of all, fatigue. What is it, fatigue? This is the subjective sign. So what is it subjective? Subjective usually, symptom. Subjective always means that patient describes him or herself what they have about their symptoms. In some cases, we can, of course, cross-check it, easy to or not, but related to the fatigue, unfortunately, we cannot. We have to trust the patient. But we might see also some additional signs how patient looks like. As well, there are the special questionnaires about the fatigue, about the chronic fatigue, which are also differ from each other according to the condition which leads to the fatigue. Like, for example, it could be questionnaire for the patient with cancer, it could be questionnaire for the patient who have autoimmune disease, and so on. So those questionnaires just additionally assist us to identify the severity of the fatigue and as well to compare after treatment also whether it is changes, is it rising or it's absolutely disappears. But indeed fatigue, again, we have to trust our patient because this is the subjective symptom. So how they usually might describe it, they can say, I don't have stamina. When I wake up, I am already feeling so tired. I have no idea how I will go to work. Or they say, I just reached my work, but I had the feeling like I was working very hardly throughout the day. So that is generally, of course, each of them, they have their own description, but at least you will understand that patient talks about the fatigue. If they mention the word weakness, we have to clarify what do they mean under the word weakness, because weakness in the contrast to fatigue, that is the objective sign. Objective means that I can measure it. So exactly weakness I can measure because it is related to the strength of the muscle, and later when we will make the assessment of musculoskeletal and neurological disorders, I will teach you how to measure the strength of the muscle because there is the common scale by which we assess the level of the strength. So if this is weakness, it means that patient has either myopathy or neuropathy, or we have the concrete structure which is responsible for the weakness. What we don't have during the fatigue, we cannot locate first of all, because fatigue is provided by many systems, and among them the central nervous system has the highest impact on formation of the fatigue. So what could be underlined reasons for the fatigue, many. So it could be started from the malignization, it could be related to the chronic diseases, it could be related to anemia, it could be related to endocrine disorders, and even some drugs might lead also to the feeling of the fatigue. Usually, the open-ended questions always help us to get the idea about the feelings of the patient, but as well they might lead us to the finding of the right diagnosis. So these two, we distinguish now what is fatigue and what is weakness. Fever, chills, and night sweats. So fever, we know what is it. This is the abnormal rising of the temperature, which has also few grades, like the mild, the moderate, and the severe high fever. So chills in fever. What is important to identify? Does patient really have fever, or they just feeling feverish? Very often patient might tell you that yesterday I had fever or 3 days I had fever. Of course, the first logical question will be what to ask. How much? So when we are asking how much was your fever, they say, I don't know, I did not measure it. So they just were feeling feverish. So feeling feverish, that is the subjective feeling, subjective symptom. But objective would be when patient tell us, I felt feverish, and after I measured my body temperature, I found out that I had fever, and they will give you the number of it. So in this case, of course, there is fever, or we are just measuring ourselves. Yeah? So we make this because body temperature, this is one of the vital signs which must be assessed in the patient despite they have complaints or they do not have complaints about feeling feverish. Chills. Chills also here, it could be like the related to feeling cold, which is purely subjective, or real chills where you're asking, did you see the goosebumps on your skin, or have you been shaking? So that is the real chill. And night sweats. When chills usually occur, when body temperature rising abnormally, that time usually patient feels chills or they're feeling cold themselves. After temperature rises and after that, and especially when it starts to go down, then patient feels hot. So night sweats. What is the reason for the night sweats? Of course, even high external temperature usually does not lead to the profuse sweating. Yes, even in the summertime we can sweat in the night, but we are not sweating so much that we have to change our bed sheets, our pajama, or what we are wearing. So the normal distribution of the body temperature, it fluctuates within the circadian rhythm. And in the early morning, usually it is lowest because throughout our resting time, metabolic rate is also low. We do not do any activity. We just sleeping, we just laying, resting. So therefore, the body temperature goes down. Throughout the day, usually by the evening time, if we measure the body temperature, it rises in comparison with the morning temperature. But it's not rises abnormally. Just if we compare morning findings and the evening findings, we will see that there is the difference between them. It's absolutely normal because we are moving, we are doing some activity throughout the day. There is the muscle work, which eventually leads to the production of the head, which increases the core body temperature, and therefore this normal gradation of the temperature considered to be physiological change. So when night sweats occur, when this swings in the temperature between the morning time, between the period when there is no increased body temperature, and usually it rises during the many of the diseases in the nighttime, but this swing is usually dramatically differs. So, and therefore it needs to the night sweets. So night sweets, which are profusely usually sweet in patient, when they tell you that I had to change everything what I want, I had to change even bed sheets and so on. So that is absolutely abnormal. Generally, two conditions might lead to such swings. First, it could be tuberculosis, and the second, this is the malignancy. So another very important question which we usually assess, that is the body weight and changes related to the body weight. Of course, the increase in the body weight also not good sign, but indeed the more concerning, like the red flag for us, that could be the weight loss. About the increasing of the weight also we will talk, but let's start with the dramatic lose of the weight. So first of all, what kind of lose of the weight considered to be concerning factors? Within the last 6 months, if body weight unintentionally drops 5% and more, we consider to be that is the concerning symptom or red flag. So what means unintentional? If person says that I decided to lose my body weight and therefore I changed my diet, I changed my sedentary lifestyle into the more active, so patient exercises, then that is absolutely normal. Of course, if it does not have any clinical signs also. But the weight change which I am talking now, that is generally related to the some underlying condition. So the first what always comes to the mind, that is the malignization. But aside from the malignization, there are many reasons which might lead to the changes of the weight. First, so we have to ask about the food intake. Is the food intake the same or something has changes? And if it has changes, what was the reason? So first it could be, for instance, that is the anorexia or absence of the appetite, which as well could be the result of some condition, but as well of the medications. Therefore, we are asking about the medications which are taken by the patient. So another reason, the let's say the in anorexia, this is non-specific sign, what means that it might have other different underlying reasons, but one of them we should rule out in the young females, that is the anorexia nervosa, which actually we can just give the treatment of the physical conditions or somatic conditions, but this is condition when additionally we have to make decision to make the referral of the patient to the psychiatrist, because sometimes just physician is not able to deal with this condition. As well could be like the bulimia. So anorexia nervosa, that means when the young female or when they have some ideal image of the girl like they want to be. So actually this is the absolutely changed perception and acceptance of their body image, or she might be just 45 kgs, but she looks into the mirror and she sees the woman who is 100 or more than 100 kgs. So that is just figuratively, of course, I explain. So what they do, they usually dramatically restrict their diet. So we have to ask about the food intake, like amount as well, what kind of food they are taking. But another reason with the, let's say, same underlying cause, it could be the bulimia. Bulimia is the opposite. Usually they have the binge eating, but after binge eating, they feel themselves like guilty, and therefore they have also the clandestine vomiting. Of course, patient might not mention about this, but there are some other signs during the examination which you can see. For example, you will see the ruptured capillary network on the face, especially if the color of the skin is fair. Additionally, one of the signs could be this is the bilateral enlargement of the parotid glands, which could be just either during mumps, during alcoholism, or it could be related exactly to the clandestine vomiting during the binge eating. So we said that the reason of the weight loss could be like the anorexia, malignancy. It could be related to some of the drugs which are taken during diabetes, some types of the antidepressants also. Uh, it could be related to the GI tract disorders as well, like the malnutrition, malabsorption. It could be related to the metabolic conditions like sometimes diabetes, especially type 1 diabetes, or it could be related to the hyperthyroidism also. In here, patient will tell you that I have good appetite, I eat much, but indeed I am losing the weight. So that is the reason of it. This is the increased metabolic rate during the hyperthyroidism. As well, very important to make here the functional assessment, especially in disabled people, especially in the people who are elderly, or just elderly who, especially males who just lost the spouse. And so therefore we are asking about the conditions at home. Very important to check also oral cavity and to see whether there are any ulcerations, or maybe there are the problem with the dentures, or there are problems with the teeth, and so on. So reasons could be many related to it, but it's the concerning symptom for us because first of all we always try to find a life-threatening condition like the cancer. So related to the weight, increasing of the weight. First of all, also here is worth to ask how fast this happened. If patient mentions that it happened within few days, let's say the maximum 1 week, never think about the cause like the adipose tissue. That is the more probably this is the put up of the weight because of the collection of fluid in the body, which could be related with the heart insufficiency, kidney insufficiency, and of course it could be related to the liver insufficiency or failure as well. So within the few days, usually patient never puts on weight at the expense of the adipose tissue. So if this is the expense of the adipose tissue, also if we see the even the visually overweight, we know that the body weight always it's not the vital sign, but this is the parameter which we always have to identify. So what is the BMI and how to do this? I hope you know, but indeed I will remind you. So we need to weigh our patient. We have to measure the height with the stadiometer, and the findings, the readings which we get, they must be in the kg and they must be in the meter. So if you are using some other units of measurement, you have first of all to change them. And then there is the formula by which we calculate the BMI, and here also we identify the normal and abnormal parameters, like if it is less than 18, then we say this is the underweight or there is deficit of the weight. From 18 to 25 up to 25, of course I just round up here because in reality this is 24.9. I just will not use it, I will round up now. So from 18 to 25 it considers the normal body weight. 25 to 30, this is the overweight. 30, 35, that is already the first degree of the obesity. 35 and up to 40, this is the second degree, and more than 40, there is the third degree of the obesity. So just a few words about the overweight. Overweight not always means that there is adipose tissue collection. Of course, we additionally visually make the assessment of the patient, sometimes even in the overweight just patient or having the BMI just between 25 and 30. But if you see that there is the fat deposition in the waistline and the abdomen, we need additionally to measure waistline with the centimeters, and as well we have to measure also hip circumference and then compare the ratio of them, because The certain numbers of this ratio might be signal that patient has predisposition to the metabolic disorder like the X syndrome. It could be predictor of the cardiovascular disorders, obesity, and the diabetes type 2. So that is only if you see the deposition of the fat of the adipose tissue in the abdominal area and the waistline. If there is no such deposition, this measurement usually is required to do if BMI exceeds 35. So 35 and more, we make additional measurement. Now another thing about the overweight. Suppose you have the young man, your patient, so you make this measurement and you get the BMI which is equal to 26, even 27. So the making the visual inspection or assessment of the body shape is very important, because if we have the male who is young, healthy, who is exercising and his lean body weight, lean it means without fat, but those who are intensively exercising, regularly exercising, usually they have the increased muscle mass. So therefore, in such patient, if you get the number like 26 or 27, it's considered to be absolutely normal. So it's not the concerning weight, it's not the concerning number to think that there is overweight and advise the patient to reduce the weight. No, because this happens only at the expense of the lean body mass, which is related, this is the muscle hypertrophy related to the sporty activity. So that is with the weight change generally. So we are going now in health promotion. Of course, it's very important. This is the dietary type. This is the sodium intake, especially when you have such history, when patient tells you that they recently very fastly I put up the weight. That means that there is accumulation of the fluid. So one of the reasons could be to ask about the salt intake as well. And of course, this is the exercise activity or physical activity, which is very important in the health counseling. That is that we have to educate, to advise our patient that 30 minutes per day of the physical activity. The 30 minutes could be divided in elderly people into two times, like 15 minutes and 15 minutes. So it's for must to do minimum 5 days per week. So to collect like the 150 minutes of physical activity, which helps to keep the condition, to keep the maintenance of the fitness. So general survey, or which we actually start from the first hello with the patient, or we are screening the patient. And meanwhile, when we started the screening and the talking with the patient, we as well, we usually already start our process of clinical reasoning. And this clinical reasoning is not only the physician's duty, that is the duty of any healthcare provider which works with the patient. So in general survey, we usually start with the general appearance or how patient looks like. It's very easy. So, state of health. Is patient look healthy? Does patient look severely ill or acutely ill? And so on. That is the state of health which usually you write down in your part of the history. The second level of consciousness, or very important for us to identify, is patient awake, alert, and responsive. And here comes exactly those questions like to identifying whether patient confused or not confused, whether patient oriented or disoriented. About this, we were talking in the first lecture. So abnormal levels of the consciousness which require the emergency care of the patient. Yeah, the first of all, why we do identify the level of consciousness to make decision in the triaging of the patient. Might be physically patient looks like everything okay, but you see abnormal level of consciousness. So immediately this patient goes to the emergency care by the triage, by the standard triage. Why? Because if there is abnormal level of consciousness, it means the problem in the brain. And this problem might have the different reasons, started from the injury, it could be related to the abnormal circulation, it could be related with the hemorrhage, but it could be related to metabolic disorders also. So what are the abnormal conditions, levels of the consciousness? So the first we said the normal alert, and usually that we write down that patient is alert uh, and oriented to person, place, and time. So that is what is the standard which each healthcare provider has to fix in the history taking. So the second one, abnormal, lethargic. And lethargic means that patient is drowsy. But this drowsiness usually is not caused by the lack of the sleep. That is not abnormal drowsiness. That is the normal. If you stay awake all throughout the night, of course, the daily time, you will feel, maybe not will be lethargic, but you will feel sleepy. So I'm not talking about such condition. I'm talking about the lethargic, or you come to the patient and patient has closed eyes, like looks like sleeping. You call by name, they open eyes usually, they manage to answer you properly the question, whatever you are asking, the general question like how are you and so on. But as they answer, they usually again fall asleep. So if you see again, I say the lethargic patient, it means that patient requires emergency care. The third level of the consciousness, that is the obtundation. Obtundation, that is someone like they they cannot even properly answer. The patient opens eyes maybe and they give you answers, but those answers are not so, let's say, the full how they must be. So stuporous means, or generally the obtundation, to easy understand, it could be like related when person is very drunk. It does not mean that patient drunk, what I say now. Obtundation, just to give the explanation how it looks like the patient who is obtudated, that is kind of very drunk person when they inappropriately given you answer. So stuporous patient usually reacts to the nauseous stimulus or the painful stimulus. They might not react even to the calling of them. So that means the damage goes deeper in the brain. But usually they do not give you answer, and in such cases, that there is necessary to assess by the Glasgow coma scale and they decide. So in the coma, we have also the superficial coma, but we have deep coma also. So comatose patients, usually they are assessed by the Glasgow coma scale, where we have the minimum number, that is this 3, and the maximum number is 15 when patient is alert, so it's the absolutely normal, and 3 when there is no response from any levels of the patient, even on the nauseous or painful stimulus. So that is the level of consciousness. I explained a little bit more in order that you understand why it is important to assess. So first of all, as I said before, to make the triaging of the patient, we are to send. So signs of distress. When we are talking about the distress, that is generally we are talking about either cardiac or respiratory distress, which are very visible usually. It could be the pain distress. About pain, we will talk a little bit later also. But if you see the pain distress on the patient, it depends, of course, on the severity, on the intensity of the pain. But once the pain is intensive, which we grading usually, not we, sorry, when patient grades it 8, 9, 10 out of 10, they have some obvious behavioral, let's say, behavioral specificities with the pain. It could be some specific posture. They might hold that area, cover with their hand, look always where the patient is diaphoretic. Diaphoretic means that they are profusely sweating. Why? Because when the pain is intensive, there is activation of the autonomic nervous system, which exactly leads this like to, it could be pallor of the skin, it could be diaphoresis also, there could be some grimacing. Well, so it's very standard pain behavior. But pain, later we will talk, this is also this purely subjective sign, and I cannot measure it without the patient. So cardiac or respiratory distress, that is generally both of them. Cardiac, if we are talking distress, which usually can develop with the acute myocardial infarction. So it has as well some behavioral changes. There are some associated such findings like this, like the fear of the impending death. So patient will say, "I am dying, I am dying." But additionally, of course, cardiac distress has dyspnea as well, like the respiratory distress. Therefore, we will see some signs of them, which one of them that is the posture of the patient. So when there is the respiratory distress, the posture, especially when it is related to the asthma, for example, they have such specific position when they are leaning forward, because during the respiratory distress related to the asthma, there is the problem with the exhalation, because there is such strict bronchoconstriction and patient cannot exhale the air, which leads exactly to this distress. While when there is cardiac, there is the opposite. In cardiac distress, patient has problem with the inspiration, so they might like try to take off the clothes, they try to open the window, say, no, I cannot catch the breath, like that's not the enough for me. So that is the one of the reason. Always pay attention on the involvement of the accessory muscles into the respiratory process. Usually we never use them, we use the intercostal muscles and we use the diaphragm, that is the normal tidal breathing for us. But when there is the distress, always look at the neck muscles like the scalene muscles, sternocleidomastoid, sometimes even platysma takes part in the respiration. So you will see like they are shrugging the shoulders as well. Sometimes there is involvement of the abdominal muscles also, because this everything assists with the respiration, but that is not the usual way. Usually we do not use those muscles. So these are the signs which help to identify the cardiac and respiratory distress. I am talking now a few minutes about this, but you must have the skill just to make the look to understand that patient has respiratory or cardiac distress. So you have to distinguish them from each other, and in your clinical reasoning, you have to make the decision what will be the next step in the management of the patient condition. So anxiety or depression also. Anxiety very often follows or accompanies exactly such distress conditions, acute pain, severe pain, I'm talking. And you will see the patient usually, they're restless. They cannot get one position. They cannot stay in bed, for example. They cannot stay in one place. They might also, like, you shake the hands with the patient, but you're feeling that the hands are wet, or they're cold and wet. That is also activation of the sympathetic innervation. Therefore, that is more characteristic for the anxiety. While the anxious patient will ask you many questions about the condition. Why? With the depression, we see the absolutely opposite. They might not be eager even to answer our questions. They might avoid the eye contact, look like the apathic, don't care about themselves, and so on. So this is also what we have to assess immediately. Skin color and obvious lesions. So uh, skin assessment, that is also another thing, but at the moment of the general survey, and therefore always the best to make general survey having the good lighting, or you just put on, you turn on another additional lighting if you have opportunity to do the skin assessment, especially on the natural light. That will be the best, but not always is possible. So in skin color, what we have to identify first of all, pallor, because pallor very often, that is the, as already I mentioned, pallor, that means the uh, bloodless, like the pale skin. So pallor very often exactly shows us the stress condition in acute case, although pallor of course could be related to the kidney failure, it could be during the left-sided heart failure, or it could be during the severe anemia also. So, and obvious lesions if they present, like, so look at the skin and we start with the color, but as well we see some other elements if they, or eruptions of the rash which present on the skin. So another abnormal coloring of the skin that could be the very important, especially in the case of the uh, acute management. If you see, that is the cyanosis, and cyanosis can be peripheral and can be central one. For central one, usually we observe on the lips and on the tongue and the other undertongue sublingual area. So therefore, when you look at the face of the patient, you see the bluish discoloration of the lips, always asked to open mouth, to stick out tongue, and to elevate the tongue to assess the skin of the mucus. Peripheral cyanosis usually present on the tips of the fingers, tips of the toes. Sometimes it could present even on the tips of the ear and even tips of the nose. That is the less frequently. Usually it present on the fingers and the toe tips, but indeed we have to assess this everything. So both of them, they have their own explanation. Usually, central cyanosis is related to the advanced lung diseases, while the peripheral cyanosis is related to the heart failure. Although, in the severe cases, when you have the patient with the severe distress, and when there is the advanced condition of the failure of one system, usually these two systems, they are related to each other. So it won't be surprising if in one patient you see presence of the both cyanosis, like the central one as well the peripheral one. Of course, jaundice. And jaundice, first of all, when you check the skin color, you will see the first where jaundice usually easiest of all to identify. This is the sclera. So therefore, never miss to check the sclera of the patient. So bruises can be related like to the injuries, but it could be related to the some blood and other disorders also. So dress, grooming, and personal hygiene. That is during the general survey. Or again, general survey, it's when we are scanning the patient. So I make the scanning and I check everything from top to toe, and making this like the analyzing in my mind what could be the reason. So what we are checking in dress, of course we are not checking are there brands or no, how properly patient is dressed, or what will be the inappropriate dressing. So always compare, is it appropriate to the season or no? Now imagine that you are getting the patient who is in the pretty warm environment. They are wearing many clothes, which is not appropriate for them. It could be related to the some reason. First of all, you always ask about, in such cases, about the cold intolerance, because cold intolerance usually could be related to the hypothyroidism, but sometimes the aging people also, they cannot tolerate cold so much. But indeed, in the especially aging people, it could be just manifestation of dementia, because they just cannot analyze how properly to dress and go out. Uh, so as well, in young females, be cautious when you see that she's inappropriately wearing many clothes. Look at her, because that when they are trying to mask their anorexia nervosa, because they are too much skinny. They are not even slender, they are not even slim, they are skinny literally. So, and they realize that because people look at them, therefore they might get on more clothes which are not, let's say, related to the season and to the weather condition as well. It's not, I don't want to like to emphasize just the young age, but indeed the drug abuse, we are usually of course facing such patient in the younger ages. So the same in the, for example, very hot environment, but if you see that your patient wears the long sleeves later on the physical examination, you make, please check the traces of the needle. Sometimes they mask exactly this bruises or traces of the needle because of the drug abuse. So on the contrary, what we might see that patient, because despite of the colder environment, they wear, let's say, less clothes. It could be related with the hyperthyroidism. Or again, if there is the elderly people, be sure not to overlook the manifestation, if not even the manifestation, but that is just from your first look. So you understand what I try to explain. I am scanning and my mind immediately thinks about all possibilities and clusters them together. So grooming means, sorry, in the dressing, I would like also to draw your attention. Look always on the foot, on the shoes. So as well, that sometimes you will see that shoes are not appropriate to the season. So they might wear either the bigger size, large shoes, or you might see some like the cuts in them, which just the sign that they try to decompress the areas of the stress, or patient has such severe edema in the lower extremities that, for instance, they cannot use the usual shoes and they might come even in the slippers because they feel comfortable in those slippers. So shoes also very important later on when you will assess like the gait and this everything. Usually the gait assessment we ask patient to do with the bare feet, but in the same time we always take the shoes and we assess to see the soil how it is worn. Very often this exactly the pattern how they are wearing the shoes, how soil is worn, might give the idea about the deformities or some other changes. So grooming, that is the how we look after each other. So look at hair, bird, if patient has bird mustache and this everything. Especially it could be very indicative in the females, in the younger females, but not just the younger females, because as usually females never go out without looking into the mirror, without making up themselves. I mean to be in the normal shape, even more even when they stay in the hospital, if there is no acute condition. So sometimes they ask their personal things to groom themselves, so that is very important. Why? Because lack of the grooming in the patient might be suggestive for the depression. And depression is very important to identify immediately. Of course, later in the mental status assessment, we are given some specific question like to screen the depression. But why it is important to identify? First of all, when you make such assessment, you have to make decision with which problem you are eligible to manage, and when you need to involve physician, and moreover you need to involve the specialist. So depression, that is the one, like the dementia also, and anxiety as well. This is the moment when we have to involve as well psychiatrist. Therefore, the early identification of this problem is very important, especially depression, because depression has one very serious danger. This is the attempt of suicide. And we never know, maybe patient when leaves our office or the hospital or clinic, does not matter, they will identify, they will attempt the suicide. Therefore, it's very important to reveal. So one of them, that is exactly dressing, grooming, and personal hygiene. The person who is usually depressed, they pay less attention. So if you look at the women, first of all, by the facial expression, you will understand, by the unwillingness to talk to you, avoid sometimes the eye contact, or they tend to cry very easy, to start crying very easy. So look at their grooming also. If you see that she's not groomed well, you see the residuals of the hair color dyeing, you see the residuals of the nail polish. I don't say that this is the standard. Patient might come to you just not having enough time to, let's say, to remove the residuals of the nail polish, but that is the small brick, or as I love to say in our clinical reasoning, we have usually, I love to compare with the puzzle collection. So each patient, that is the puzzle, and therefore even small part of this puzzle sometimes gives us very big clue to find out what happens with the patient, what makes the condition of the patient worse. So personal hygiene, that is, I cannot now attribute immediately to some of the changes in the mental status, though they might be the serious signs of the mental status changes, among them the mood disorders like the depression, although that is sometimes just related to the habits of the patient. So about the personal hygiene, and eventually, there are some, this very the subjective perception. For somebody, that is, it could be the very important, for somebody less important, but that is again one of the bricks which helps me to build up the big picture about the patient. So in the personal hygiene, look at the dress, of course. This is the smell. And smell is very important also, because, for example, if you smell urine or fecal smell from your patient on the skin, that might be the, let's say, one of the signs that they have incontinence. So there are different types of the incontinence. Let's say they say bladder incontinence. I'm not stopping now here, but the smelling of urine means that patient is leaking. And very often, if there is this leaking, of course, this is the involuntary leaking, they feel embarrassed to talk about this. So in your, like, the generating the question, when we make the full assessment in the comprehensive yes assessment, you have to very carefully ask about this, because patient might feel embarrassed to tell you, to complain about this. On the other side, also, again, I will emphasize here the patient who developing dementia. That is the functional incontinence. They don't have any problem structurally with these systems, but they functionally, or they do not understand, they do not analyze to go and to use the toilet. Or it could be related with the functional also incontinence, when patient is disabled and just the settings at home are not enough. Therefore, in our functional assessment, which later on I will discuss, it's very important to ask and to assess such specificities. And again, this is not the duty just of physician or just of nurse. This is duty of each healthcare provider which works with the patient to make assessment. Because eventually doctor might see only one time, but the second, third, and fourth time, as a nurse or as a physiotherapist or as an occupational therapist, you will see the patient more often than the doctor, and therefore these cues are very important eventually to inform the doctor about this everything, because very often, for example, about the dementia, especially in such settings where it's not acute condition like the rehab center or some other institutions, exactly other healthcare providers who are working almost daily with the patient, they start to see those changes, those small changes which require the attention. So therefore it's very important to see this everything also. So personal hygiene, we say. The next one, what we are assessing, this is the facial expression, of course. So look like the facial expression, it could be sometimes even the aggressive, which as well could be related to the, let's say, the fear, or with the even the dementia, or patient stares at you and you're just surprised why he or she is staring at me, but that is just the stare of the hyperthyroidism. Or it could be like the mask expression of the face, which is characteristic for the Parkinson disease. Parkinsonism, this is the in general. When there are other conditions which remind the Parkinson, or conditions which affect the basal ganglia, and sometimes this is just the first sign of this condition. So usually such apathic or absent expression of the face during the depression, and so on. Odors, or as I told you, it's very important. And about the, let's say, odor of urine and feces, we already mentioned. And other specific odors that could be like the fetus hepaticus, which is related to the chronic liver disease and liver failure, most of all, or uremic odor as well, which is very specific. When you go just to the patient and you already identify that here is the kidney failure, or here is they are very, very specific. Once you smell it, you will memorize for all your life. Or for instance, you go to the patient and you are smelling the smell of the vomiting masses. So you already know, maybe there is nothing like the evidence there, but at least you know the patient just vomited, and that's why there is very important as the alcohol, yeah, and odor of the ketoacidosis, which is kind of the acetone smell. So just by the smell, when you just come to the patient, sometimes you already know to which system to deal, what is the problem here. So alcohol odor on the breath. It must not confuse you if you have the patient who is having obtundation. You remember that obtunded patient, they behave or they are talking with you like the very drunk people. So don't overlook the problem in the brain. Exactly after the alcohol intake, it might lead to the metabolic poisoning of the central nervous system. And maybe therefore your patient is obtunded now, but feeling the smell on the breath does not mean that patient is just drunk. Even in drunk people, we have to rule out that there is no, for instance, there is no the affected central nervous system. Posture, gait, motor activity. So posture we said already. So, but it's very important to see how patient is standing, how they are sitting. Is it the acquired because of the some injury, some forcefully, of course, let's say because of some underlying condition. So even with the respiratory distress, by the position of the body, you can distinguish, is it the cardiac distress or is it the respiratory distress? Because as I told you, when there is related to the, for instance, asthma, patient usually leans forward, what helps them to breathe out, to exhale. So additionally, you will also hear there are very audible wheezes on the breath. But when there is the cardiac distress, which is related with the usually pulmonary edema, which develops as a result of the left-hearted failure, the patient usually has orthopnea. Orthopnea, this is the position of the patient when they cannot stay in the horizontal position because it just increases the pressure in the lung circulation. Therefore, they usually sitting upright, not leaning forward, but sitting upright with the legs with the feet, so put on the floor, so not in the air, not dangling legs, but no, the feet are usually on the floor. So restless or quiet, that is also, this is the anxiety. But for instance, in the case if you have the patient who are having the abdominal pain, to distinguish whether this pain is visceral or is it the parietal, which is related with the inflammation of the parietal, of the peritoneum. Even in this case, their motor activity is absolutely different. Whoever has the visceral pain, usually they are restless. They cannot assume one position. But who have parietal pain of the inflamed peritoneum, they stay very still. They avoid even small movement, even they avoid the coughing, because it just increase their pain. So gait that will be the different assessment about which we will talk in the later lectures. So height, weight we said, and now let's go to the vital signs. So we have 4 vital signs, and I don't talk now about the pulse oximetry because actually it's considered like to be the vital sign, but that we are taking with the special instrument also, like we are using the special instrument for the blood pressure measurement. But generally, we have the 4 standard vital signs. That is the body temperature, heart rate, blood pressure, and respiratory rate. So, few words about them. How to check the heart rate? Actually, that is not the heart rate. That is the pulse rate. We use radial artery, like putting our 2 fingers. Later, I will find the picture and show you. And so how we do this, we have watch with the second hand, of course, and with our second and third finger we identify the radial artery, and we count amount of beats, pulse beats, exactly in 1 minute. So aside from identification of how many times you palpate these beats per 1 minute, that is the pulse rate, we have to assess as well rhythm of the pulse, and the rate could be regular, and regular rhythm means that each beat follows after the previous one in some certain amount, the such standard time. Or it could be irregular when we say there is the arrhythmia, and then the beats usually they are not felt in the equal time, between the equal times. But if you get the irregular, let's say, pulse, now additionally you have to assess, is it irregular regularly? What means that regularity usually occur after certain beats of the normal beats of the pulse, or they are irregularly irregular. Irregularly irregular means it's totally not identifiable rhythm. Why it is important? The last one which I mentioned, suggestive for the atrial fibrillation. And in this case, obtaining of the pulse on the peripheral artery absolutely not reliable. That means that we have to get the stethoscope to place it on the apex of the heart, not the apex itself, on the projection of the apex or point of maximal impulse, which in adults we usually find, of course, on the left side, unless there is no dextrocardia, in the 5th intercostal space on the mid-axillary line. So we put the stethoscope there and we count the heart rate. Now I'm talking about the heart rate because we are getting it from the apical beats, and we count it within 1 minute. So that is why we need to identify the pulse rhythm in order to know, is it regular, irregular, but in case if it is irregularly irregular, we must shift on the apical pulse and measure, count the beats in that area and then record it. So what we have to know as well now, respiratory rate, or that is the amount of respiration or inhalation and exhalation which is done within the 1 minute, and the normal range usually that is between 12 in adults, I mean between the 12 and 20 respirations per minute. Some books give a little bit different variation, but we have to remember that this range 12 to 20 considered to be the normal rate. So how to obtain it? We never inform if about all other procedures. We have to inform the patient what we are going to do with them. In this case, we distract the patient attention, because if they focus their attention on the respiration, they involuntarily start to change the rate of it, like the involuntary controlling, if we can say so. So therefore, usually we pretend, very often we pretend this when we are checking the pulse on the radial artery. So our patient thinks that we are still checking the heart rate, but meanwhile we are assessing, we are looking at the abdomen, or we are looking at the chest in females on the movements of the chest, and we are counting usually if it is regular, which more often will be the regular, will be enough to check within the 30 seconds and then just multiply by 2. But if you see that respiration is irregular, in this case, we are counting the respiratory movements within 1 minute. So as well, very important to see the not just the rate of the respiration, but as well to see the depth of the respiration. Is it deep? Is it superficial? So when the respiratory rate usually starts from 24 and up, we call it tachypnea. And if there is 10 and less, we are talking about the bradypnea. And sometimes when that is the very acute condition, if you get it less than 10, so it means that there is necessary to start also the basic life support. Well, related to the heart rate or pulse rate, the normal range usually in adults we are seeing from 60 to 80, although it's considered to say that normal heart rate is 60 to 100, but just always add in adults and adolescents, because for adolescent 100 beats per minute still normal, while for adult this is the mild tachycardia. So blood pressure. Blood pressure we measure with the sphygmomanometer, and there are a few types of sphygmomanometers, among them which is the mercury type. Usually it's not used anymore because there is the danger for the breaking of the glass where is the mercury and exposure to the environment, which is dangerous. Although there are some types of the stationer, such mixed types, which are very precise, because mercury, this is one of the best in case of the exact readings. But if you have such a stationary one in your clinic, in your hospital, you will use it, or if not, generally there are two types. One is so-called digital electronic one, which is very good for the monitoring, especially the self-monitoring of the blood pressure when patient does not require to use additionally the stethoscope and just to see the readings, though the less accurate, exactly, this is the electronic one. But of course, if you have to measure the many patients, let's say in the department, then they will force you to do this with the aneroid sphygmomanometer. though you know that in all steps, which clinical steps which you have to pass exam, we are using usually the aneroid or the manual assessment where it's necessary to use additionally stethoscope also. So the technically you will, I hope that you know how to do this, but you will go through the techniques of the measurement here, and I very much hope that we will have the a meeting with each other where I will of course show once again how to do this. So we need to have the aneroid stethoscope, and we need to have the aneroid sphygmomanometer and the stethoscope. So the blood pressure measurement has two steps. The first step, usually we identify approximate systolic pressure. Why it is important? Because first of all, we never know how much the blood pressure of the patient at the moment. It could be normal, it could be low, or it could be very high. So there is no average number which considered to be the good for getting the to inflate the bladder until this number, because in case if blood pressure is normal or even low, if we pump more or inflate more, we just overcompress the brachial artery, which we are using for the auscultation during the measurement, and it will just lead also to the misreading, because after the compression, over compression, when there is the blockage of the deeper vessels as well, when you start to deflate the bladder or release the air, in this case blood gets the turbulent blood flow and creates extra sounds which prevent us to identify the first Korotkov sound or the first beat which we hear usually in the stethoscope. I don't mention about the discomfort and even pain for the patient during such measurement. On the other hand, if patient has increased blood pressure, but I do not inflate enough to that number, it means that I underestimate the real systolic pressure. And there is another so-called on waterstone, that is the auscultatory gap. When we measure the blood pressure and between systolic and the first systolic and the second one, the sound, there is the gap or no pulsations. This is characteristic for the patient who have arterial stiffness or who have atherosclerosis, and therefore we might underestimate systolic pressure up to 50 units, which you understand that it is very important. So therefore we need to do the first step in the measurement, where we do not auscultate the brachial artery, but we are using pulsation on the radial artery as well. We can use the pulsation of the brachial artery, or you put your two fingers on the radial brachial artery. That is up to you. Personally, I use radial artery. Why? Because if I put on the brachial artery, then I have to remove the stethoscope, then put it again. Therefore, the first step I provide, palpating the radial artery. Then I start step by step inflating the bladder. So inflation must be very careful, like 2, 3, up to 5 units per each of the pump. So I continue this, and in the same time I look at the readings at the scale, and I continue inflation until I do not lose the palpation, or I cannot palpate anymore radial pulse. Why I cannot palpate? Because I already compressed the brachial artery, and blood does not flow to the more distal direction. So as I lose the feeling or palpation of the radial artery, I look at the scale and I see the number and I memorize this number. So suppose this number was 130. So I immediately after that I release or I deflate the bladder fully until I see the arrow returning to the 0 point. I give minimum 10 seconds for the normal circulation of the blood flow in the upper extremity. And after that, now I start the main measurement. So the number which I got in my first attempt by palpation, that is the approximate systolic pressure. Approximate means that I know approximately how much it is, but now I have to confirm exactly, and plus I have to identify diastolic pressure also. So how I will do this? During the main measurement now, when I put the stethoscope on the brachial artery, and again I start the process from the beginning, or I start inflating bladder, I will inflate up to number which I get with the help of the first measurement. Or if I get 130, which is corresponding to the approximate blood pressure, systolic blood pressure, I have to add up just 30 units will be absolutely enough to avoid underestimation, over compression, and as well avoid the very important auscultatory gap, if it present, of course. So that means that I will inflate bladder till the reading 160 and then carefully deflate the bladder and auscultating now the sounds which will appear when blood flow uh, again starts to go through the brachial artery. The first sound, which sounds like the pulse in my ears through the stethoscope, is first Korotkov sound, and usually it is corresponding to the exact or precise systolic pressure reading. Then you will auscultate diminishing sound of the pulsation. Usually they are about 5, but you do not count them. We just continue auscultation until the last fading, the most diminished sound you auscultate through the stethoscope. That will be the diastolic pressure reading. So then we will, of course, write down the reading, which will be, let's say the upper one, the maximal one will be systolic, and the lower one will be the diastolic. So what could be not challenging, let's say, but a little bit problematic in this case. First, this is the reaction on the so-called white coat. So the generally patient, when they are getting this measurement, they might be a little bit anxious, what increases the possible systolic pressure. A little bit, but indeed you will get not correct reading of the blood pressure. Therefore, very important that you never rush to check the blood pressure. You can start with the the peripheral pulse assessment with the respiratory temperature, like to make the calm down the patient. As well, very important to make the pre-assessment of the condition, like the asking the patient whether he or she was physically active. I'm not talking about exercise, I'm talking about any type of the activity. 20 minutes prior to the measurement, whether the patient got any caffeinated beverages before, which as well artificially might increase a little bit because of the caffeine systolic findings especially. Then we have to ask whether patients smoke cigarettes, because cigarette smoking also leads to the activation of the sympathetic innervation, which as well might lead to the increasing of the blood pressure. And usually if you see that it is slightly elevated, you have to measure after maybe 5 or 10 minutes, when let's say after the first one patient calms down, and again we are measuring. So that is the first, that is the like the reaction on the white coat. So another thing could be challenging when we have the patient, so before we check the peripheral pulse, we remember, and we assess the regularity. So when we have irregular pulse, which is suggestive for the atrial fibrillation. So we said that neither pulse is reliable to be checked and recorded, and we are shifting to the heart rate calculation on the apical pulse area or PMI area. But the same will be problem, not reliable will be the blood pressure measurement also. Why? Because again, I am checking it through the peripheral artery. I am not getting the beats from the heart. Yeah, so therefore, in such patients, usually it is advised within the 5 minutes, approximately such differences, to check, to measure blood pressure with the intervals, and then we have to find out the mean reading for systolic as well for the diastolic, and write down. Indeed, in the record we have to mention that this is the mean reading, it's not the exact reading, and what is the reason for it. So one time there is necessary, always minimum one time per each, especially the new patient, that we have always to measure on the both upper extremities. That is to check whether there is the difference between the left and right hand, which normally it's assumed that up to 5 it could be the normal one. And as well, we have to check one time on the upper extremity and the one time on the lower extremity on the popliteal artery also. Especially it's important in the new patient, in males who are more prone to have the coarctation of aorta, and in this case we will see this such very significant difference between the findings, between the readings on the upper and the lower extremities. So that is the generally the techniques. So you see how we place the cuff of the sphygmomanometer. The pipes always must be on the anterior side, which are corresponding to the antecubital fossa area. So you locate the stethoscope before. Usually by palpation, I find the best position where I can palpate the pulse easily. And after that, usually I place the stethoscope there. Challenging could be the patient who has obesity. Yeah, regarding obesity also, before very important in the getting the precise readings is to find the correct size of the cuff. So the standard cuff usually works with the standard body type having people. But if you have extremely slim cachexic patient or slim by such physics just they have, you can use pediatric cuff. While if you have the patient who has obesity and usually the normal cuff does not work with them, we cannot place it effectively. In this case, you can use the cuff which are used for the measurement on the leg. So it will work much better. So the rest usually in the management about the blood pressure is taken by the physicians. Is it necessary to make the home blood pressure monitoring, or if there is necessary to do this such golden standard 24 hours measurement with this special device. It's like the monitoring. But the first what you have to know, this is of course technique and how to make the interpretation of it. So that is the white called hypertension, which I mask it hypertension. This is the opposite. When patient comes to you, they have slightly elevated, they have, let's say, the normal usually blood pressure in the office, but they complain that at home they have more than 135 when they make the measurement. So musket is more dangerous. Dangerous, I mean, in the risk factors for the cardiovascular outcomes. And therefore, such people and who have also nocturnal hypertension, they are advised to do 24-hour ambulatory blood pressure checking. That is when patient comes to office, the special device is usually put on, and there is necessary to give the programming how often it will measure, and among them the measurement must be done, of course, in the night time when patient has a rest or even the sleep. And the last one, what we have from the vital signs, that is the this is the body temperature. For body temperature, we have usually the few sites for it. Of course, they have the different reliability, but whatever is available, whatever will be the protocol in your clinic, that way you will of course use. So we have oral temperature, we have axilla temperature, we have rectal temperature, and we have the tympanic temperature. So out of these four, the less close to the core temperature, because we try to identify the core temperature of the body, which always differs from the outer parts of the body. And of course, out of these four, the less of all comes closer to the core temperature, that is the axillary temperature, which we are checking in the axillary area or in the armpit. Usually depends which type of the thermometer you are use. Nowadays, of course, everybody tries to shift to digital one. First of all, they give very fast reading within the just very short time, maybe sometimes less than a minute in the axilla, but usually in the rectal and in the oral areas, it gives even within the 10 seconds, 10 seconds the reading already. Well, but each of them, they have their indications and contraindication. That is not only what is available for us, but that is also those existing contraindications, which for instance prevent me for the measurement in the oral cavity. So between the oral cavity and the axillary temperature, there is approximately 0.8 averagely of or half by Celsius. There is the difference between them, and between oral and rectal and the core temperature also differences, small differences. Therefore, we say that axillary less of all precise, and if I put into the line, let's say less precise towards the most precise, I can distribute the following way, like the axillary temperature, then the oral temperature, then rectal, and then the tympanic one. So as you see, the tympanic one usually requires the special type of the thermometer, tympanic thermometer, which has the infrared beam on the tip of it. It has the specific shape as well. And if you technically correctly place it and make the correctly measurement, then you are getting the exactly core temperature. Why? Because the hypothalamus is very close to the area of to the site of the measurement, and those wet beams also help to identify this core temperature. So what could be the indication? Contrary, oral temperature is the most frequently used in almost in all countries, although in Georgia we are using the axillary measurement. This is the very standard measurement. Just we take into consideration how much is the difference between the core temperature and between the axillary temperature. So first of all, before any type of the measurement, whatever which site we are using, we have to make the inspection of that site. Inspection whether there are any skin disorders or any inflammatory processes which just will artificially, of course, increase the reading from the temperature and can mislead us regarding the fever. Fever, we know this is the central, it's condition from the body. It's not related to the local things, but local changes like inflammatory changes, they might change the measurement, the reading of the measurement. So as I said, the oral one very frequently used almost in all countries, but we have to identify what are the contraindications. So first of all, we make the inspection of the oral cavity. And during the inspection, of course, I will check whether there are any ulcerations or there are any inflammatory changes which might increase the reading of the measurement. This is the first. The second, children, they are not required. We cannot check them in the oral cavity because they might just they might clench the teeth and just damage the thermometer. And especially imagine if you are using the glass thermometer. So glass thermometer is not absolutely used now, not required to use during the oral measurement. So we said children, so any inflammatory processes. The next one in the assessment, we have to ask the patient whether patient has taken any hot beverages before the measurement, which within the 30 minutes, 20-30 minutes, because as well they are increasing hot beverages the local temperature and it needs time to cool down, but as well also hot and spicy food as well will change the local temperature. So that means that if you need to check, you will use another site like the same axillary temperature if you don't have the tympanic one, but not in the oral cavity. And of course, cigarette smoking, because cigarette smoking as well locally will change the temperature. As well, the history of the seizures and unconscious patient prevent us. These are the contraindication for the getting the oral measurement. So rectal measurement, if you do not have tympanic one, if you cannot access in the axilla, then generally the rectal measurement could be done in infants, and as well it is done in the unconscious patient also. The general contraindication for the rectal measurement will be, that is the, if patient is conscious, refusal by patient, we cannot force to measure them if they don't want to do this, or there is the presence of some any inflammatory or skin disorders in the area, or the mucous disorders in the area of the measurement. So you see that you have to choose what will be the more appropriate in the case. And eventually we are coming to the tympanic measurement. So in the tympanic measurement, first of all, we have to make the assessment with the generally otoscope. We need otoscope to assess the external canal because first of all you have to see whether there are any inflammatory processes as well any discharge. The second, if there is the wax present there, serum, wax present there, that means that we cannot get the measurement. It won't be the precise reading because it prevents the thermometer to have direction to the membrane, to the tympanic membrane. Or why I make the otoscopy first, to identify the condition of the external canal, to see whether there is the wax or no. And the third one, you have to identify where tympanic membrane is, because later on, when you insert the thermometer into the ear, into the external canal, you have to locate in such a way that the tip with the red beam will be directed towards the tympanic membrane. That's why it's very important to assess before the measurement. So after that, if you do everything correctly technically, you are getting the core temperature of the body, as you understand, which is very, very important and precise. So usually tympanic measurement we get from the both of the ears, and which shows the higher reading. That reading usually is recorded. That is regarding the vital signs. And now to the I want to shift to the pain. This is like the fifth of the vital sign. And from our first lecture, we remember that pain or any other symptom, you remember that we have 7 classic attributes which we must assess per each of the symptom, including the pain in the patient. Why? Because exactly finding out about all of them helps us to identify the source of the pain and type of the pain. Well, of course, I will go to the assessment, but first of all, I want to make such the classification by the timing of the pain. Yes, and we know that there is the acute pain, there is chronic pain, and between them there is such condition when patient has some acute pain. So what is it acute pain? Usually which just manifests or freshly appeared. Usually it is severe, not often it's severe, not usually, it's often severe. It continues, sometimes it disables patient. The reasons can be many, starting from the injury and ending with the visceral organ pain. And usually when pain is acute, patient seeks to the help for the help, and they come to us, to healthcare providers. In such type of pain, when it is acute and severe, I told you during the when we were talking about the general survey that it is very often accompanied by anxiety and very specific behavior, and even the when you see the patient, as I told you, we might see the activation, the signs of the activation of autonomic nervous system. So usually acute pain continues 7 up to 10 days, not more. Then we are shifting to the subacute, which continues, if still continues, if there is no such acute condition which is the life-threatening, because pain, it like shows us usually there is disaster somewhere, and when pain is severe, especially, we have to identify to rule in or rule out the life-threatening conditions. That means that if I do not give immediate or emergency care, patient might die. So usually, if it continues more than 10 days, it shifts to the subacute stage, and eventually, depends on the condition, of course, on the disease, it eventually might shift to the chronic pain. So the chronic pain usually, let's say that there are few descriptions of it. They are a little bit different from each other. So the first one, that is the pain which continues 3, 6 months or even more, and which is not related to the cancer, because like fatigue is one type of the fatigue attributable to the cancer, the same we have with the chronic pain. So when we say chronic pain, but when we mention not associated with the cancer, we already rule out the presence of the cancer in this case. So again, not associated with cancer and which continues 3, 6 months. That is the one definition. Another definition, that is which continues more than 1 month, or we have some disease, acute illness or injury, but the presence of the pain continues more than 1 month beyond the condition. And pain which recurring or comes and goes, and this can continue even years. So that is the chronic pain. So approximately we can say that if pain continues more than 10 days up to minimum 1 month, but generally the averagely they say that 7 weeks, 7 weeks, that is the subacute pain. After that, we are shifting to the chronic pain. What is characteristic for the chronic pain? Let's say that it changes life quality. Exactly, you as a physician usually, of course, also assess all this everything, not just the severity, but very important from physiotherapies, from occupational therapies, and from the nurse also to assess what kind of functional limitations or even disabilities are resulting from the chronic pain. So usually it is not so intense like the acute pain, because then if it is very intense, now those people already know that they need to seek the help with the healthcare providers, maybe even go to the hospital or call the ambulance. So, and very important here that patient has an idea how to deal, or they're managing, somehow they are managing. Either they using the over-the-counter medicine themselves before they come, but that is generally will be the patient who comes in the subacute case, with the subacute, because eventually, even with the subacute, they start to look for the help with the healthcare professionals. So in majority cases, they know how to deal with it. But indeed, even if they look for the healthcare assistance, that is because of the exactly function limitation. And very often it could be associated with the depression. And here is very, very important relation of these two conditions coexisting with each other. Chronic pain leads to depression. Yes, and that is the normal because limits daily life activities, limits the quality, reduces significantly the quality of the life. But on the opposite side, also the patient who have depression, they prone to have the chronic pain. So here is will be very important to distinguish this depression is result of the chronic pain or asymptomatic depression becomes the reason of the chronic pain, because uh, look what happens if there is depression which is result of the chronic pain. We manage pain, depression will go. But if depression is primarily occurs like the primary condition, then what we remember that here there is necessary to involve other healthcare professionals, other specialists like the psychiatrists, because sometimes just dealing with the depression with their drugs reduces perception of the pain. The next chart just explains pain best of all. So we see in the middle pain, and we see a lot of, let's say, the not attributes, but this is the everything about, yes, the pain. So we have the sensory, for instance, when we which purely this is the out from those attributes of the pain, like the intensity, quality, pattern of the pain. Yeah, so what kind of pattern? Or we have physiological also, like the location, onset, duration, etiology, syndrome. These are all questions. Affective means how patient shows themselves. That is the affection during any symptom, condition, or disease. Or what we see, we assess mood state. Yes, and you remember this is also from the general survey. So patient just comes with the pain, but we are scanning them throughout everything. So like the mood state, anxiety, depression, well-being, because this everything, they are interrelated with each other. Cognitive, or we usually ask the patient, what are your insights about your problem, or what do you think about your problem? So meaning of pain for them is absolutely different. So view of themselves, coping skill and strategies. And coping skill, yeah, it might have like how can you manage your pain. So and they give you some their coping skills, or maybe they cannot even absolutely cope, they don't know how to do this. Are there any previous treatments, attitudes and beliefs about this pain? Beliefs very important also to get into consideration, because sometimes they might have very weird beliefs, and beliefs this is exactly thing which we have. We can of course make decision about beliefs, can we modify them or no, because there are some certain beliefs which we never touch, they are untouchable. This is the religious beliefs. But if I see that there are some lay theory beliefs about any symptom of the pain, of course I can modify. How to modify? Given just the education and given the best explanation. So after they understand the root of their problem, of course, first of all, they will be agree to follow your suggestions how to deal with it. But on the other hand, they understand better, let's say their enemy, so-called enemy, so they can cope better with it. So, and other factors influencing the pain: behavioral, so communication, interpersonal interaction, physical activity, pain behavior, medication, this everything what we have to take into consideration in the pain management, and then make the decision. So by the mechanism of the pain, we have, so we have the few, let's say, mechanisms of the pain which help us to identify the reason, first of all, of the pain, but on the other hand, it helps us also to go to the correct direction how to deal with this pain. First, nociceptive pain or somatic pain. although it could be visceral also. So visceral, you understand, they are related with the internal organs, like it could be the hollow organ, it could be some other organ also. So nociceptive means that there are the receptors, nociceptive receptors, which are located in the tissues, and they give afferent information or drives into the central nervous system, where this is the very, very complicated process of the pain. So what I can say that here, sensory system usually not involved. It works properly. It works absolutely properly. When this type of the pain appears, it appears when there is the damage to the tissues, somatic, any musculoskeletal injury, any of them. Visceral, if visceral, for example, well, let's say the gallbladder colic. So this is the best. The problem inside of the tissue, and the afferent impulsation goes to the brain and also gives the result we have the pain. It could be indeed modified by the some let's say imaginary things when we non-pharmacologically also we try to help and so on, because some behavioral also changes might help to deal with the pain. So neuropathic pain, from the name we already see that there is the involvement of the nervous structures, and here is somatosensory already impairment, somatosensory. So if in first one we didn't have sensory, let's say, altered any processes in the sensory system. But in the neuropathic pain, there is, it could be related to the central nervous system damage, like for instance, it could be stroke, or it could be brain and spinal cord injury when we have the central pain, neuropathic pain, or it could be related to the peripheral sensitization, like it could be during, if there is the compression on the disc, on the nerve root by the prolapsed discs. Yeah, so there is the compression which leads to the pain in the nervous structure. So that is the neuropathic pain. Indeed, what we have here also damage, not damage, the, yeah, the damage of the tissue. Well, central sensitization, that is the more complicated type of the pain. Here, impaired sensitization comes, or with the sensory problem. First of all, what we have, the lower threshold of the pain, lower threshold. It means that the patient who usually suffers from the central sensitization pain, and generally now I am talking about the chronic type of the pain, these two, they could be acute, but they could be the neuropathic, could be both, they could be chronic also. The central sensitization, generally this is the chronic pain, or the first of all, the threshold of the pain is lower, but indeed the perception of the pain in the brain also impaired, or they percept is more than usually other people do this. The best example for the central sensitization type of the pain, this is the fibromyalgia. And you know that there are just chronic pain which goes throughout the body, and almost it's very difficult to deal with it with the standard pain management, like the non-steroids, or which work perfectly in the first two cases, like this non-steroids, or if there is necessary non-steroids. Why? Because when there is damage of the tissues, there is the vasoactive, let's say the nose neuropeptides and other compounds which are pro-inflammatory, or there is always inflammation, and therefore the, let's say, the standard treatment usually gives the result. In case of the central sensitization, you will not have, because there is no damage of the structure, there is just impaired perception. uh, Better understand, this is very interesting, it is still under the study, this type of the pain. There is also such description from the patients that they might perceive the pain from the stimulus, which usually is not painful, normally is not painful. Like, for instance, massage therapy. They cannot, because they say that it is painful, while majority of people say that no, it is relaxing, it reduces pain, because this is one of the means how non-pharmacologically we can reduce the pain. So that is the one. The second one, usually they say that this is from the childhood, that they perceive it usually more than others, the same stimulus. Another thing what they might mention also, that when, for instance, some um, not irritants, but some, let's say, substances like the perfumes, or when they go to the supermarket and they are walking in the aisles with the perfume, or the household things like the washing powder, so on, they immediately start to experience headaches. So that is one extra, let's say, sign for this type of the pain. So, psychogenic pain, generally we are dealing here psychogenic, it's less also chronic pain. This is generally chronic pain. And when we have the patient who usually do not respond long time to the pain, but meanwhile, when we have the pain, what we are doing, we try to find anatomical substrata which is responsible for it. So in the psychogenic pain, and even in the central sensitization pain, usually we cannot find such substrata, or there is no damage on the anatomical structure. Indeed, pain exists. So what could be here underlying also problem? Anxiety, depression. This is worse exactly to ask patient about the such, let's say, things like the drug abuse, or um, even the marijuana. So when we say the illicit drug, marijuana is not included into the illicit drugs, although marijuana, this is also the different type what we have to ask, because, for instance, in the weight loss, also it's worth to ask about the drug abuse or the marijuana withdrawal. But if you remember, in my first lecture, I said that about the sexual history and the drug history, we always ask if it is appropriate. So psychogenic pain, that is one of the reasons when we are asking about the possible drug abuse. So sometimes it could be also like the when somebody uses over-the-counter painkillers very frequently, they have the opposite result also. And eventually we are coming to the idiopathic pain. And by the word idiopathic, what we know, that idiopathic usually means that we cannot find the cause which leads to the pain. So if you rule out everything, then there is just what remains for us, this to say this is the idiopathic pain. So how we make the assessment of the pain now? First of all, of course, we ask about the location. Yes, the time we already mentioned, that how long do you have this pain, and then we make decision, is it acute, is it subacute, or is it chronic. And what we always have to remember, in acute, of course, we have to take into consideration all all of the attributes, and among them the location, that there is nothing what could be the life threatening. Okay, so that is the first thing, the acute pain. So location and radiation, because pain could be localized in one place, it can travel or spread throughout the body from the source of pain to another part of the body. But very important also to differentiate radiation of the pain from the referred pain. So they are not the same. Radiation means I have the source of pain, or patient identifies the source of pain here, but it shoots somewhere in the other part of the body. That is the classic radiation. Referred pain means the problem in one system of the body, but pain might appear in another part of the body. The best example that you can memorize it, that will be the myocardial infarction of the inferior wall, that sometimes patient presents with the pain in the epigastrium, which could be accompanied with the diarrhea, with the vomiting. So we will focus our attention on the GI tract, on the stomach first of all, but meanwhile there is absolutely different. So that is the referred pain, or certain parts of the inflamed pleura during the pleurisy, uh, because pleura has the different types of the innervation, and therefore the certain parts of the pleurisy pain, it might be referred as well to the upper part, to the epigastric, let's say the upper level of the body. But we will think that there is related with the abdominal problem, but indeed there is related to the absolutely different organ in the body. Yeah, so that is the referent. Just a few words how to distinguish what is radiation and what is the referent pain. So location, the best question, because patient will tell you, I have pain in my chest, I have pain in my arm, I have pain in my abdomen, and so on. Immediately, please point with your finger exactly, or outline with your finger. Sometimes they can point, sometimes they exactly will outline the area of the pain. So that is what we do the first. The second, in the body, or you will have the body chart, which comes with the usually assessment sheet. I just two types I show you. It could absolutely different designs, it does not matter. And so the easiest way that you have the medical chart, and even you can show the patient and say, could you exactly point at which area they show on themselves, show them chart also, or you transfer yourself on the chart. So here you see just front and the back side, and here additionally on such type, I don't know what type of the chart you will have. Will you have them or no? This is also, it only dependent on the, let's say, what your hospital or clinic or department will use. But that is what we are doing. Yes, so first we ask, and then either we mark on the body chart or we record immediately where. But you understand that during the recording now, you localize anatomically. You do not repeat what patients say. Patient just shows it, but by the shown area, you have to localize anatomically, like writing it is epigastrium, is it the periumbilical area, is it the right right iliac fossa, and so on, or it's on the anterior chest, it's on the posterior chest, in the, and so on, femoral area, and so on. Okay, so what is important also, because here as well we have to make decision in our clinical reasoning how to manage the patient, that is the intensity. And for intensity of the pain, generally there are other types also of the charts which will be used in your working places, which generally they are dealing with the chronic type of the pain, but the fast assessment for the pain, these are the following. You see the charts where we have, this is the visual analog scale, this is the just numeric scale. Sometimes just students, they think they are the same, but as you see, there are differences between them. And there is the phase scale. So the usually what the simplest way, what we are asking, on the line from 0 to 10, where 0, no pain at all, and the worst pain possible is equal to 10, please rate or grade your pain. As you see, I cannot assess. Indeed, this assessment totally belongs to the patient responsibility. And we know that from 0, 0, this is the no pain, 1, 2, 3, 4, that is the mild pain, 5, 6, 7 considered to be the moderate pain, and 8, 9, 10, that is the intensive pain. So intensive pain usually, but majority they say that 7 also. So 7 a little bit, it's like the bordering pain. And therefore, be cautious with the 7. Sometimes it could be considered like the moderate pain, like the limit of the moderate pain, and starting of the severe pain. So with other clinical signs, even 7 might make the decision that there is the patient for the emergency care. What is difference between the visual analog scale, or if here I have purely 1, 2, 3, 4, 5, here we have the 100 millimeter, you see, or 10 centimeter. And usually patient tells me, for instance, for the numeric scale, I can rate my pain like the 6, and I will just write down 6. But when we have the visual analog scale, we usually ask patient, please point, because they look at it and look now what will be different. it's much more different. It's much differences between just saying 5 and between saying that, for instance, this is 5 point maybe 3 or 5.8. In both cases, when we have numeric one, patient will tell me this fine, 5, it's not the 6 yet, but between 5 and 6, it will be even more grades. And this is especially used in the emergency care, uh, especially because we start the pain management. And again, by these two, patient will show, even for instance, pain was half an hour ago 5.5 and now it shifted to the 5. Yes, if it is just the numeric one, they will still say that it is 5, but if it is visual analog scale, indeed we depend on the patient, but it might show dynamical progression of the pain or regression of the pain. And eventually these are the such faces expression. There are different designs also, but when it works, first of all, don't forget that you might deal with the children who still does not know the numbers, and even the such abstract thinking is not yet developed in them. You might have the patients who have retarded development. They are adults, but they have retarded development, and therefore they just don't have the equal education. They needed special training to adapt for the living only, and therefore they cannot answer you with the numbers. So we just show them, and as well, it's working in such cases. Okay, let's imagine such condition when you do not have interpreter, you don't have translator, but you have the patient who does not speak in your language and just gives you idea about the pain. Yeah, so we are just showing those facial expressions, and they will understand, trust me, what happens with them, and they will show to which, let's say, what kind of feelings they have because of the pain. And so, okay, so as I calculated correctly the functional assessment and ICF, I will give you on the next lecture because today I don't have time to do this. Well, so after we find out this everything, we have as well to differentiate now. First of all, this is musculoskeletal or this is the systemic pain. This is very important again and again in the management, in the clinical reasoning. So, and you see that here very standard very standard description, or if you remember, we are asking the patient what makes pain worse or what facilitates the pain, what makes it easier. So if we know generally lessons at night, that is musculoskeletal. Sharp or superficial ache usually decreases with cessation of activity, I mean the physical activity. Usually continuous or intermittent, or it means comes, goes, and aggravated by the mechanical stress. It could be some position or doing some specific activity. And one thing is important also, when we ask to show with finger, they exactly able to show where is this pain, very exactly. This is very common for the musculoskeletal. So systemic pain, what we see here, that there are other underlying conditions which lead to those changes, not all of them, but any of them puts, let's say, such question mark what is more dangerous or more complicated underlying conditions from the system. So first of all, disturbed sleep. And generally, that is when there is the neuropathic pain, they cannot rest because it just hurts, it just aches, and that is deep aching or throbbing, reduced by pressure, constant or waves of pain and spasm. It's not aggravated by any mechanical stress, by any position. Associated with the following, like the jaundice. Yeah, jaundice always shows that there is either problem in the biliary tract, or even it could be related to the pancreatic cancer, although jaundice, which is related with the pancreatic cancer, does not have the history of the pain before. But when there is jaundice and before it was pain in the abdomen, in the upper abdomen, that is more probably that there is the blockage of the biliary tree. Migratory arthralgias, because migratory, they are characteristic like for the rheumatic fever, arthralgia, this is the pain in the joints, or it could be like the rheumatic fever, it could be gonorrhea also, skin rash, because behind the skin rash and the pain, especially in the joints, it could be related such systemic disorders, autoimmune disorders like psoriasis or like systemic lupus erythematosus, fatigue. Fatigue, we know that this is the non-specific sign of many dangerous conditions. Weight loss, the same. Low-grade fever. Low-grade fever might show some infectious process, among them the tuberculosis. So together we just collect again the one picture that I know that at least it's not related with the musculoskeletal, because the musculoskeletal the easiest of all to manage. But when we have underlying systemic conditions, it is more difficult to manage, because first of all we have to find the culprit for the pain, and after that we have to know what to do with it. So low-grade fever, because low-grade fever, it's not just the infection, but it could be more serious condition, but because of the immunocompromisation, the fever does not react like usually. Low-grade fever could be even in the elderly people, because their immune system naturally does not work so well like it was in the young ages. Generalized weakness. It's also a weakness, we said, that is related to the muscle strength, and when there is the generalized weakness we should think maybe there is something related with the process which affects the central nervous system, peripheral nerve, generally could be both even. Cyclic and progressive symptoms. Progressive means that something worsens and worsens. Cyclic means goes calm, and plus progresses together. So progression could be in the duration of the pain, progression could be in the intensity of the pain, in the settings of the pain, and so progression could be in any of the related attributes. Tumors, or if I have the history of tumor, any new or progressive pain, I should attribute to the tumor unless is not proven opposite. That is the standard way, like rule of thumb. And of course, history of the infection plus pain. That means that I have to look for something more, let's say, serious. Okay, that is for today what we did, or we know how to make the assessment or general survey by the inspection of the patient. So we know as well how to make the assessment or the measuring of the vital signs. And we know also about the pain and how to make the assessment of the pain. So just one thing, what I jumped here, that is the later after you do this everything on the examination, physical examination, you try to identify trigger points. This is possible to do only by palpation, or when you press with your fingers you identify the painful or tender areas. And sometimes you might feel, especially if those trigger points are in the muscles, you will feel such like tight bands or the such hard hard tissue under your finger. Indeed, it's not always related to the musculoskeletal system. Sometimes those trigger points, they could be result of the problem in another organ. Absolutely. So that is for today, and the next week I will continue with the functional assessment, which is as well very important, and we will discuss also about the ICF. This is the International Classification of Functioning and this Health and Disability. So for today, goodbye. So you have to read chapter 4 fully, of course, skim the text. You don't need to go in such depth like is necessary for the MD program. But what about I was talking, please focus your attention on those parts of the text. Of course, including the health promotion, you have to know what are the main concepts, what we are using, and how we are educating our patients, because this is also our role to do, and it does not matter which type of the healthcare professional you are. So again, chapter 4, and for pain, you can use even the my presentation as well. Generally, presentation is not material to prepare for the exams, for finals, or for midterms. You always have the reference of the book, and please follow the book chapter, which is mentioned in the syllabus or even in the presentation also. So we will meet in 1 week. Wish you nice day and goodbye for today.